Your medicine cabinet tells a story. The bottles lined up on those shelves represent decades of accumulation, some prescribed years ago for conditions that may have changed, some purchased over the counter because they helped once and might help again, some recommended by friends or family members who meant well. You know approximately what each one does, though the details have grown fuzzy over time. You take them as you always have, in the doses that seemed right when you started, trusting that what worked before continues to work now. But your body at 75 is not the body that first received those prescriptions at 55. The organs that process medications have changed. The brain that responds to their effects has changed. The balance between benefit and risk that once favoured taking a particular drug may have shifted without anyone noticing. The medicine that helped you then may be harming you now, producing symptoms you attribute to getting older, rather than to the pills you swallow each morning and night. This is not about alarming you into stopping medications you need. This is about awareness that could prevent a fall that breaks your hip, could preserve cognitive function you assumed was simply declining with age, could protect kidneys and hearts and minds from accumulating damage that occurs so gradually you never connect it to the bottles in your cabinet. I want to walk you through 5 categories of everyday medications that commonly cause problems in people over 70. Not exotic drugs or obvious dangers, but ordinary medicines available in every pharmacy, often without prescription, used by millions of people who have no idea that their age has transformed these familiar substances into potential threats. The first category involves medications that block a chemical messenger in your brain called acetylcholine. These drugs are called anticholinergics, though you would never know that from reading the label. They hide in common products you might take for allergies, for sleep, for cold symptoms, for bladder control. The most familiar example is diphenhydramine, the active ingredient in many over-the-counter sleep aids and allergy medications that have been sold for decades. When you were younger, your brain could tolerate the anticholinergic effects of these medications without obvious consequence. The drowsiness they produced might have been welcome if you were using them for sleep. The dry mouth and constipation were minor inconveniences. The cognitive effects, if you noticed them at all, resolved quickly as the drug cleared your system. After 70, everything changes. Your brain has become more sensitive to anticholinergic effects because the acetylcholine system, which supports memory, attention, and mental clarity, has less reserve capacity. Blocking this system with medication produces effects that go beyond drowsiness. Confusion emerges. Memory becomes unreliable. Thinking feels sluggish in ways that do not clear quickly. The drug that once helped you sleep may now be contributing to the cognitive decline you attributed to normal aging. The research on this connection has become substantial and concerning. Large studies following older adults over years have found that regular anticholinergic use is associated with increased dementia risk. The relationship appears to be dose-dependent, with greater exposure correlating with greater risk. The mechanism makes biological sense. You are chemically blocking a system essential for cognitive function, and in an aging brain with diminished reserves, this blocking produces measurable harm. Beyond cognitive effects, anticholinergic medications increase fall risk in older adults. They cause drowsiness that persists longer than expected. They produce dizziness and unsteadiness. They affect vision in ways that impair balance. The fall that sends someone to the hospital, that begins the cascade of complications often ending in nursing home placement or death, may have been set in motion by a simple over-the-counter sleep aid that seemed harmless because it required no prescription. The easy availability of these medications creates dangerous assumptions about their safety. You can walk into any store and purchase them without consultation, without anyone assessing whether your age or other medications make them inappropriate for you. The absence of prescription requirement feels like permission, like evidence that the drug is gentle enough for anyone. This feeling is profoundly misleading. Regulatory decisions about prescription requirements involve many factors beyond safety for elderly users. A drug can be dangerous for you specifically while remaining available for general purchase. If you regularly use antihistamines for allergies or sleep, particularly the older sedating types, this warrants conversation with your physician about alternatives. Newer antihistamines with less anticholinergic effect exist for allergies. Sleep problems often respond better to addressing underlying causes than to medications that suppress symptoms while creating new problems. The nightly pill that helps you drift off may be stealing your cognition and threatening your balance in ways that matter far more than a few hours of improved sleep. The second category involves medications prescribed for anxiety and sleep that belong to a class called benzodiazepines. Names you might recognize include diazepam, lorazepam, alprazolam, temazepam. These drugs were often prescribed decades ago when understanding of their long-term effects in older adults was less developed. Many people have taken them for years, sometimes for so long that they cannot imagine sleeping or managing anxiety without them. Benzodiazepines work by enhancing the effects of an inhibitory neurotransmitter in the brain, essentially calming neural activity. This produces the relaxation and drowsiness that made them popular treatments for anxiety and insomnia. But in older brains, this calming effect extends further than intended, affecting balance, coordination, memory formation, and mental processing speed. Fall risk increases dramatically with benzodiazepine use in older adults. Multiple studies have documented this relationship. The drugs affect the reflexes and coordination needed to catch yourself when balance wavers. They impair judgment about what movements are safe. They persist in the body longer than in younger people because aging liver and kidneys clear them more slowly. The pill you took last night may still be affecting your stability when you rise tomorrow morning. Cognitive effects from benzodiazepines can mimic or accelerate dementia. Memory formation is impaired while the drug is active. In some people, these effects do not fully resolve even after the drug has supposedly cleared. Long-term use has been associated with increased dementia risk in epidemiological studies, though debate continues about whether this represents causation or correlation with underlying anxiety or sleep disorders. The dependency that develops with extended benzodiazepine use creates its own set of problems. Your brain adapts to the presence of the drug, down-regulating its own calming mechanisms. When you try to stop or reduce the medication, rebound anxiety and insomnia emerge that feel worse than what the drug was originally treating. This rebound is the brain recalibrating, not evidence that you still need the medication, but distinguishing between these feels impossible from inside the experience. Stopping benzodiazepines after long-term use requires careful medical supervision. Abrupt discontinuation can produce dangerous withdrawal effects, including seizures. But gradual tapering, supported by alternative approaches to managing anxiety and sleep, is possible for many people and may dramatically improve cognitive function and reduce fall risk. The dependency is not permanent. The brain can recalibrate, but the process requires guidance and patience. If you have taken benzodiazepines for years and assumed you could never stop, this assumption deserves questioning. Geriatric prescribing guidelines consistently identify these medications as inappropriate for most older adults except in narrow circumstances. What was considered acceptable treatment decades ago has been reassessed in light of accumulating evidence about risks in aging populations. The prescription you have been refilling automatically may represent outdated thinking that your current situation no longer supports. The third category involves pain relievers that belong to a class called non-steroidal anti-inflammatory drugs, commonly called NSAIDs. The most familiar examples are ibuprofen and naproxen, available without prescription in every pharmacy and grocery store. You might take them for arthritis pain, headaches, muscle aches, general discomfort. They seem gentle because they are available so casually, because you have taken them since middle age without obvious problems. But the risks of NSAIDs increase substantially after 70, particularly with regular use. Your kidneys, which are responsible for clearing these drugs and protecting themselves from their effects, have lost filtering capacity with age. What your kidneys handled easily at 50 may stress them significantly at 75. Each dose of ibuprofen asks your kidneys to perform a task they are less able to accomplish safely. Kidney damage from NSAID use in older adults can be subtle and cumulative. You might notice nothing until a routine blood test reveals declining function that has been progressing silently for months or years. The damage often cannot be reversed once it has occurred. Kidney function that took decades to decline naturally can drop precipitously when stressed by regular NSAID use. Cardiovascular risks also increase with NSAID use, particularly in people who already have heart disease or risk factors for it. These medications can raise blood pressure, can promote fluid retention, can increase the risk of heart attack and stroke. The relationship is well documented in medical research and has led to warnings that many people have never read or have long forgotten. Gastrointestinal bleeding represents another serious risk. NSAIDs damage the protective lining of the stomach and intestines, creating vulnerability to bleeding that can be life-threatening. Older adults are more susceptible to this complication, and the bleeding can occur without obvious symptoms until enough blood has been lost to cause problems. The accessibility of these medications creates a false sense of safety that is particularly dangerous. You can purchase them without anyone asking about your age, your kidney function, your heart health, your other medications. The regulatory system that made them available without prescription did not contemplate that you would be using them regularly into your late 70s while taking multiple other drugs that interact with them. If you rely on NSAIDs for chronic pain, this reliance deserves review. Acetaminophen, while not perfect, may be safer for many older adults when used appropriately. Topical preparations that deliver medication locally without the same systemic exposure exist for joint and muscle pain. Non-pharmacological approaches including heat, physical therapy, gentle movement, and addressing underlying conditions may reduce reliance on daily pain medication. The solution to chronic pain is rarely indefinite use of drugs that accumulate harm over years. The fourth category involves medications that reduce stomach acid, particularly those called proton pump inhibitors. Brand names you might recognize include omeprazole, pantoprazole, esomeprazole. These drugs are remarkably effective at suppressing acid production, which is why they were revolutionary treatments for ulcers and reflux when they were introduced. They are now available without prescription and used by millions of people for years or decades. Short-term use of these medications for specific conditions poses modest risk. The problems emerge with long-term use that was never intended when these drugs were developed. When you suppress stomach acid for years, you create conditions that affect multiple body systems far removed from digestion. Stomach acid exists for reasons beyond causing discomfort when it refluxes inappropriately. It helps your body absorb certain nutrients, particularly magnesium, calcium, vitamin B12, and iron. Chronic suppression of acid production impairs absorption of these nutrients over time. Deficiencies develop gradually, producing symptoms that seem unrelated to the medication. Magnesium deficiency from long-term acid suppression can cause muscle cramps, irregular heart rhythms, and neurological symptoms. Calcium malabsorption contributes to bone loss that makes fractures more likely. Vitamin B12 deficiency produces fatigue, neurological symptoms including tingling and numbness, and cognitive effects that can mimic early dementia. These deficiencies develop over months and years, making the connection to medication invisible without deliberate investigation. Bone fracture risk increases with long-term proton pump inhibitor use, a relationship documented across multiple studies. The mechanism involves impaired calcium absorption and possibly direct effects on bone metabolism. For someone already at risk for osteoporosis, adding a medication that further weakens bones represents compounding danger. Kidney disease has been associated with long-term use of these acid suppressants, though the mechanisms remain under investigation. The relationship appears in large population studies linking extended use to declining kidney function. Whether this represents direct drug toxicity or some other pathway is debated, but the association is consistent enough to concern researchers and inform clinical recommendations. Perhaps most troubling, these medications can be difficult to stop once started. When you suppress acid production for extended periods, the cells that produce acid proliferate in response. Stopping the medication produces rebound acid hypersecretion, a surge of acid production that creates intense symptoms worse than what the medication was originally treating. People interpret this rebound as proof they still need the drug, when actually it represents a temporary adaptation that would resolve with time. The rebound can last weeks, making discontinuation uncomfortable enough that many people simply resume the medication rather than persisting through the adjustment period. If you have taken acid-suppressing medication for years for symptoms that might be managed other ways, this deserves reassessment. Many people take these drugs for symptoms that could be addressed through dietary modification, weight management, or behavioral changes like not eating close to bedtime. The medication became easier than addressing underlying causes, but the medication has costs that accumulate invisibly over years. The fifth category involves medications for sleep beyond those I have already mentioned. This includes a variety of prescription sleep drugs, some of which have become enormously popular, marketed as safer alternatives to older medications even though their safety in elderly populations remains concerning. Sleep difficulties are common in older adults, and the temptation to address them pharmaceutically is understandable. But many sleep medications carry risks that become more significant with age. Beyond the benzodiazepines already discussed, Newer sleep drugs can cause drowsiness that persists into waking hours, increasing fall risk. They can produce complex behaviors during sleep, including walking, eating, and even driving without conscious awareness. They can interact with other medications in ways that amplify sedation beyond intended levels. The relationship between sleep medication and falls in older adults is consistent across medication classes. Anything that causes drowsiness, unsteadiness, or altered cognition increases the likelihood of the falls that can devastate health and independence. The hip fracture that occurs at 78, leading to surgery, then pneumonia, then decline, often begins with something as seemingly innocent as a pill taken to help with sleep. Memory effects from sleep medications can be subtle but meaningful. Some drugs interfere with the brain's consolidation of memories during sleep. Others produce morning grogginess that impairs cognitive function for hours after waking. The cumulative effect of nightly medication use over years is difficult to quantify, but may contribute to the cognitive decline people attribute to simple aging. Alternatives to sleep medication exist and deserve consideration before accepting pharmaceutical solutions as necessary. Sleep hygiene practices, while they may seem simplistic, genuinely affect sleep quality when implemented consistently. Underlying conditions that disrupt sleep, including sleep apnea, restless leg syndrome, and pain, can be addressed specifically rather than being masked with sedation. Cognitive behavioral therapy for insomnia, delivered by trained providers, has documented effectiveness exceeding that of medications for many people. Let me step back from specific medication categories to address a broader pattern that these examples illustrate. Many of the medications causing problems for people over 70 were started years or decades earlier when they were appropriate and helpful. The body aged, but the prescription continued unchanged. Nobody re-evaluated whether what made sense at 60 still made sense at 75. This is remarkably common in medical practice. Medications get added during acute illnesses or periods of instability. They help during that period, and so they continue. Years pass. The original prescribing physician may have retired or moved. New physicians inherit a medication list and assume that what the patient is taking must be needed, or the previous doctor would not have prescribed it. The patient assumes the same. Nobody questions. Nobody reviews. The regimen persists through inertia, even as the body that receives it has transformed. The symptoms that emerge from inappropriate medication use in older adults are frequently attributed to aging itself rather than to the drugs causing them. Confusion is dismissed as early dementia rather than investigated as a medication effect. Fatigue is accepted as what happens when you get old rather than recognized as a potential side effect of something being taken daily. Falls are attributed to frailty rather than to sedating medications or drugs that cause dizziness. The symptoms seem to confirm what everyone expects about aging, which prevents investigation of their actual cause. This misattribution has profound consequences. People accept limitations as inevitable that might be reversible. They begin accommodating to deficits that could improve. They decline into dependency that need not have occurred. Family members witness what appears to be natural decline and grieve accordingly, never suspecting that a simple medication adjustment might restore the person they thought they were losing. Geriatric medicine has developed frameworks specifically to address these issues. The Beers criteria, named for the physician who developed them, list medications considered potentially inappropriate for older adults due to elevated risk of harm. Prescribers who consult these criteria can identify drugs that deserve reconsideration when patients reach certain ages. But many prescribers do not routinely consult these resources, and many patients have never heard of them. The stop/start criteria provides similar guidance, identifying medications to stop in older adults and medications to start that might be inappropriately omitted. These tools encode the accumulated knowledge of geriatric medicine into practical frameworks for decision-making. They exist because experts recognized that routine care was failing to adapt to aging bodies, that prescribing appropriate for younger adults was being inappropriately extended to people whose physiology could no longer tolerate it. If you're over 70 and have not had a comprehensive medication review in years, you are statistically likely to be taking something that is doing more harm than good. This is not speculation. Studies consistently find high rates of potentially inappropriate prescribing in older populations. The medications in your cabinet, prescribed by well-meaning physicians who wanted to help you, may have become inappropriate as your body changed while the prescriptions did not. A medication review involves systematically examining every drug you take, prescription and over-the-counter, evaluating whether it remains appropriate given your current age, health status, kidney function, liver function, cognitive status, full risk, and other medications. This review should ask whether each medication still serves a purpose that justifies its risks. It should identify interactions between drugs that amplify dangers. It should consider whether lower doses might provide benefit with less risk. This is not something you can do adequately yourself, because assessing drug appropriateness requires medical knowledge you probably do not have. But you can initiate the process. You can gather all your medications, including the over-the-counter ones, and request that your physician conduct a comprehensive review. You can specifically ask whether each medication remains appropriate for someone your age. You can advocate for reconsideration of drugs that have been continued without recent evaluation. Family members play an important role in this process, particularly when cognitive changes have occurred that might impair the older person's ability to advocate for themselves. A daughter or son who notices that a parent seems more confused, more unsteady, more fatigued than expected can raise questions that the parent might not raise. They can request medication reviews. They can help compile the complete list of everything being taken. Their outside perspective may notice changes that have occurred so gradually that the person experiencing them has not recognized them. The resistance to stopping medications can be substantial, both from patients and from the medical system. Patients may fear that stopping a drug will cause the symptoms it was originally prescribed for to return. They may have psychologically adapted to the medication as part of their identity and routine. They may distrust the suggestion that something they have taken for years might now be harmful. Physicians may hesitate to stop medications they did not originally prescribe, uncertain whether some reason exists that they do not know. They may fear that stopping a medication will produce problems they will then be responsible for managing. The time required to carefully discontinue medications and monitor the results may not be available in brief appointments. Continuing prescriptions is administratively easier than stopping them. These obstacles can be overcome with persistence and appropriate guidance. Deprescribing, the systematic process of tapering or stopping medications that are no longer appropriate, has developed as a medical discipline precisely because the need is so great. Resources exist to guide this process safely. Physicians with training in geriatric medicine understand both the necessity and the methods. When medications are appropriately stopped in older adults, the results can be remarkable. People who are confused become clear. People who are falling stop falling. People who are exhausted recover energy. Cognitive function that appeared to be permanently lost returns. These improvements feel miraculous but actually represent the removal of pharmacological impairment that was masquerading as aging. Not every medication can or should be stopped. Some drugs provide benefits that clearly exceed their risks even in older adults. Cardiovascular medications that prevent heart attacks and strokes may be essential. Drugs that control dangerous conditions cannot be casually discontinued. The goal is not to eliminate all medication, but to eliminate inappropriate medication while continuing appropriate treatment. Safer alternatives exist for many of the medications that cause problems in older populations. Pain can often be managed with acetaminophen, rather than NSAIDs, though even acetaminophen requires careful dosing in older adults. Sleep can often be improved through addressing underlying causes rather than through sedation. Anxiety can be managed through non-benzodiazepine approaches, including therapy and newer medications, with less cognitive and full risk. Allergies can be treated with newer antihistamines that lack the anticholinergic effects of older ones. Non-pharmacological approaches deserve consideration before defaulting to medication. Physical therapy may address pain that would otherwise be treated with daily pills. Cognitive behavioral therapy for insomnia may produce better long-term results than any sleep medication. Weight management and dietary changes may reduce the reflux that currently requires acid suppression. Sleep apnea treatment may eliminate the need for sleep medications. Addressing root causes is generally preferable to suppressing symptoms pharmacologically. If you are reading this and recognizing yourself or a loved one in what I have described, the appropriate response is not panic, but action. The medications in question have been taken, perhaps for years, without catastrophe. The risks are elevated, but not immediately life-threatening in most cases. What is needed is thoughtful evaluation and appropriate adjustment, not emergency intervention. Start by creating a complete list of everything being taken, including over-the-counter medications, supplements, and vitamins. Include not just the medication names, but the doses and the frequency of use. Include medications that are taken intermittently as well as those taken daily. This list becomes the foundation for the conversation with your physician. Schedule an appointment specifically for medication review. Make clear that this is the purpose of the visit so that adequate time is allocated. Bring the list. Ask about each medication. Is this still appropriate for someone my age? Are there alternatives with less risk? Could this be contributing to symptoms I am experiencing? The goal is dialogue, not conflict. Your physician wants to help you. They may simply need prompting to undertake a review that competing priorities have prevented. Be prepared for complexity. Some medications should be stopped immediately. Others require gradual tapering to avoid withdrawal effects. Some need to be replaced with alternatives before stopping. Some will be deemed necessary despite their risks. The review may require multiple visits and ongoing monitoring. This is not a single conversation but the beginning of a process. Include family members who can observe changes and provide additional perspective. Their observations about your function, your cognition, your stability matter for the evaluation. Their help with monitoring after medication changes may be essential. The process works better as a team effort than as an individual endeavour. The medicine cabinet that has accumulated over decades of life does not need to be emptied. It needs to be curated. Each bottle should be there because ongoing evaluation has confirmed that its benefits exceed its risks for someone your current age. What helped you at 55 may still help you at 75, or may not. What seemed harmless when prescribed may have become hazardous as your body changed. The years you have remaining deserve protection from preventable harm. The cognition you retain deserves protection from medications that cloud it unnecessarily. The stability that keeps you independent deserves protection from drugs that undermine your balance. The organs that sustain your life deserve protection from pharmaceutical stresses that accumulate invisibly over years. You have the right to know what you're taking and why. You have the right to ask whether each medication remains appropriate. You have the right to request alternatives when what you are taking carries risks that concern you. You have the right to participate in decisions about what enters your body. The everyday medications that fill your cabinet are not automatically safe because they are familiar. They are not automatically appropriate because they were once prescribed. They are not automatically harmless because they require no prescription. Each one deserves scrutiny through the lens of your current age and health, not through assumptions formed when you were younger. This is not about fearing medicine. Medicine saves lives and reduces suffering every day. This is about ensuring that the medicine serving you is actually serving you, that what made sense then still makes sense now, that nobody is taking pills out of habit that have become hazards through the simple passage of time. Your body deserves medicine appropriate to who you are now, not who you were decades ago. Review what you are taking. Question what has been continued without recent evaluation. Partner with your physician to optimize your regimen for the person you currently are. The bottles in your cabinet should help you, not harm you. Making sure they do is not paranoia, it is wisdom.